Hello folks, welcome to the third and final week of our Biopsychosocial Needs, Death, and Dying unit. This is the last week of this unit, so if you haven't completed reading chapters 3 and 4 in your books yet, be sure to do that. Remember that we're going to be testing on this unit, which is 3 weeks worth of material, on Friday or earlier if you've arranged it with me. I went over the learning objectives for this whole unit a couple weeks ago, but since we're shifting focus into more of death and dying, I thought it would be a good time to revisit those objectives. They are to evaluate the attitudes, beliefs, and classifications regarding death and dying, to compare and contrast responses to the process of death and the various coping strategies and mechanisms, debate quality of life versus quantity of life, and to trace the steps that are implemented when a patient death does occur in the OR. So death in the OR is a rare occurrence. However, you must understand the psychosocial and procedural aspects associated with dying in case it does happen. There are several factors that feed into a person's perception of death and dying. Included in these are religious beliefs, cultural beliefs, beliefs tied with ethnicity, the attitudes of one's family members, and the attitudes of the caregivers of the dying person. All are important for realizing a well-rounded understanding of death and dying and how people think, feel, and react to it. Your book has some really great examples in the reading, in the required reading, about how religious beliefs affect how death is thought of and how the procedures after death are affected. I believe it's on page 46. The definition of the end of life is viewed from many perspectives. It's the period of life when death is expected. Death usually follows within days of pronouncing someone as end of life. So life-saving protocols are deemed ineffective and are discontinued. At this point in time, comforting care is still provided, and death can be placed into one of 4 classifications. Those classifications are accidental, terminal, prolonged or chronic, and sudden. Accidental death, these are unexpected deaths. They can be caused by nature, like in the event of an earthquake, tornado, tsunami, or flood. But they can also be caused by humans, like in the event of a motor vehicle accident, gunshots, or other violent crimes. Terminal death refers to people with progressive and incurable diseases. So these patients will benefit from palliative care in order to improve their quality of life. Prolonged or chronic death refers to those who die from a long-lasting condition. So this is different from terminal death in that death is an expected outcome of terminal illness. The conditions that cause prolonged or chronic death are manageable for a long period of time. So some examples would be asthma, high blood pressure, and diabetes. Sudden death is a death that occurs without any warning. So stroke, cardiac arrest, and sudden infant death syndrome all fall into this classification. Death can be defined in 3 stages. They are cardiac death, higher brain death, and whole brain death. Your book addresses these stages on page 46. Cardiac death is the irreversible loss of cardiac and respiratory function, so there will be no breathing or heartbeat without any chance of those things returning. Higher brain death is the irreversible loss of higher brain function. So that means that only the brainstem continues to function, which controls respiration, breathing, and blood pressure and heartbeat. Whole brain death is irreversible loss of all functions of the entire brain. There will be a flat EEG, no pupillary reflex, decreasing body temperature, and the patient will be unresponsive. The Kubler-Ross model of death and dying describes stages of grief experienced by those who've lost loved ones. This model is broken into 5 stages: denial, anger, bargaining, depression, and acceptance. Before I go into depth about each stage, I want to bring to light some criticisms of this model. The model implies that grieving is a passive process, and like a car wash, once you're through, you're all done with it. It suggests that there's a right way to grieve, which could actually be harmful to some people who grieve differently. And there is also no proof that this model fits everyone and their bereavement process. So if the stages don't fit a person's own experience, they could think that they're grieving wrong. The written notes of this version of this lecture has a link to a journal article that goes into this just a bit more in depth, which is really interesting. I encourage you all to read it. So let's go on now to the stages of Kubler-Ross. So the first stage is denial. This is a defense mechanism against the full impact of death. We do this to give our mind an extra moment to accept it. Patients in denial will say things like, "No, this isn't happening," or "No, this can't be right." The anger stage is when the patient projects feelings on family, self, healthcare workers, or sometimes even God. This happens when they can no longer keep up the denial stage, and they'll feel frustration. So they may say things like, "Why me? Why me right now?" The bargaining stage is used to help postpone the inevitable of death. If they've finished the anger stage, but they still can't face the reality of death or impending death, sometimes they'll try to bargain. So they may say things like, "Just let me live to see my daughter's wedding," or "If I had called more, maybe she wouldn't have died." The depression stage may happen during the dying process. The dying individual may get through denial, anger, and bargaining to find themselves at great loss. This is viewed as a form of clinical depression, and it's treated during the dying process. Finally, the acceptance stage occurs when there's been enough time for the person to go through all the other stages and realize that death is inevitable. Once this acceptance is reached, there's no longer a struggle with grieving because they are feeling acceptance instead. So not all of our patients are healthy folks coming in for routine procedures. Some of them are quite unhealthy. Some of them are dying. Even patients that are dying sometimes need surgical procedures. So the encounters you may have with these patients will be brief. It's the nature of our role that the patients see us for a short amount of time before going off to sleep. It's important that you employ keen listening and observation skills because these will help you to know what you can do to make the patient more comfortable. For example, the patient may say something about the temperature of the room. This may be your opportunity to offer a second warm blanket if the first one isn't enough. Avoid saying anything to minimize, rationalize, or deny death. You don't know where the patient is on their journey through grief, and you also don't know the spiritual beliefs of that patient. So mentioning any type of God may offend your patient and cause them to be quite uncomfortable. The best thing you can do is focus on providing immediate physical and emotional comfort. And this goes back to my example of the second blanket. Placing a pillow under their knees to take pressure off of their back is another good example. Finally, if speaking with any patient, especially the dying patient, never imply that the procedure will cure the patient. Remember that surrounding the dying patient is often the dying patient's grieving family. Family has a central role in a patient's emotional environment. So while they'll be expectedly feeling grief and sadness, they might also be feeling anger and frustration. And the hospital will have a member of the clergy or chaplain that may be able to help the family cope if needed. Something to remember also is that the death of a loved one may also mean shifting financial burden onto surviving family members, which can also be stressful. In the event of an unexpected death, the family should be given privacy. There will be a designated room where the family can gather and process the news together. As a surgical technologist, you will likely not have much interaction with the patient's family, but if you do, you should refrain from providing any information to them about the death. Even though death in the OR is rare, it does occasionally happen, and when it does, that specific OR may need to be closed so that the body can be prepared for viewing by the family. Depending on the spiritual beliefs of the family, they may need access to the room for religious preparations. Let's move on now to go over some terminology surrounding death and dying. Self-determination refers to the individual's right to decide how they live or die. The Self-Determination Act was passed in 1990 and requires hospitals to inform patients of their right to choose the type and extent of their medical care, and also to provide patients with information about living wills and powers of attorney. Advance directives are documents filled out by the patient that tell healthcare providers what the patient's wishes are when the patient is unable to speak for themselves. They include a living will, which states what medical interventions the patient is willing to undergo in order to sustain life. The power of attorney appoints someone to make health decisions for the patient in the event that they are unable to. Sometimes, as part of their advance directives, patients will have a do not resuscitate or DNR order. This is an order initiated by the patient and placed by a physician to refrain from resuscitation attempts if the patient suffers cardiac or respiratory arrest. Medically, the DNR order must be respected and granted. Besides having proper documentation filed, the patient will also wear a bracelet identifying them as DNR. If the bracelet is removed, the DNR is not followed, and the bracelet will need to be replaced to reinstate the DNR order. Often, DNR orders are suspended in the OR. Anesthesia medications given to the patient during surgery require the use of life support services, so this needs to be communicated and clarified with the patient. Palliative care is not just for those people that are at end of life. The purpose of palliative care is to provide symptom relief, to avoid symptoms altogether, or to treat a secondary problem. Therapeutic procedures are done to treat or manage the patient's ailment. They can be elective or non-elective. The term life support encompasses a variety of therapies that are used to sustain life when the patient's body is not functioning well enough to do so on its own. Examples that may be used in this way include feeding tubes, IV drips, a respirator, heart-lung machine, defibrillation, and dialysis. Life-sustaining therapy can be divided into ordinary and extraordinary measures. Ordinary are the standard measures that a doctor would feel obligated to provide to a dying patient. Extraordinary life-sustaining measures are those that would put another burden on the patient and they would be costly. So, for example, if a patient is dying of pancreatic cancer and is expected to live only another week, physicians are not going to perform a craniotomy to remove a newly discovered brain tumor. This patient would experience a great burden and costs associated with the craniotomy, and it wouldn't do them any good in the end. Euthanasia is when a physician either does nothing to sustain a patient's life, resulting in their death, or they do something to actually help death happen sooner. An example would be the physician administering a high dose of morphine to help death along. The legal implications of active euthanasia especially will vary from state to state. Let's talk about the cultural responses to death and dying. Cultural competence is acquired through experience and active learning. It's something that comes with time. It's your responsibility to learn from your experiences and use the information in the future. In order to be open to learning about other cultures, you have to start with acceptance of their differences and respect for those differences as well. So page 46 of your book addresses some different cultural beliefs surrounding death. There may be some things to be taken into consideration. Depending on the cultural background, death may be considered a natural phenomenon. When a death occurs in the OR, there may be special cultural considerations for preparation of the body for viewing by the family. And regardless of the cultural considerations, preparation of the body needs to be done with dignity and respect, always. So who's the one that can determine a death in the hospital? Determination of death includes a very specific medical assessment. The surgeon and anesthesia care provider verify death of a patient in the OR together. Typically, death is determined when the criteria for whole brain death is met. Remember that this means that there has been an irreversible loss of all functions of the entire brain. So the criteria for determining death in the OR are complete and irreversible cessation of the cardiovascular system, irreversible respiratory failure that's not a result of drugs or hypothermia, absence of any response to external stimuli, so like painful stimuli, and getting no reaction from that. Cessation of cranial nerve reflexes, cessation of all brain activity measured through EEG, and a low or decreasing body temperature. While many of us have suffered the death of a loved one, most of us haven't been there to experience the death itself. There are physical changes to the body that occur upon death. The body will immediately begin cooling down. There's loss of muscle tone, which includes a loss of sphincter control. They will likely empty their bladder. Their eyes will remain open and their jaw will drop. Livor mortis is red and purple discoloring on the face, especially around the ears and the cheeks. It will also pool in dependent areas of the body. So, for example, if the patient is in a supine position, livor mortis will settle in the posterior parts of the body, like the backs of the legs, elbows, back of the head, shoulder blades, etc. Rigor mortis is a natural stiffening of the body. This begins 15 minutes after death and peaks in 8 to 10 hours. Rigor mortis starts at the head and works down to the feet. After 24 hours, the body relaxes in reverse order from the feet back up to the head. So death in the OR, like I said, is very rare. Usually, the surgical patient can be stabilized enough to at least get them to the ICU, which is a more comfortable environment for family to say goodbye to their loved one. When death does occur in the OR, there are some basic guidelines that broadly apply to the situation. The state and federal laws, as well as the hospital policy, bring the procedure into more focus per each individual hospital. The broad guidelines are as follows. Notify the surgery supervisor or the perioperative manager of the death and begin post-mortem patient care. The surgeon notifies the family and significant others. Religious leaders, like a chaplain or clergy, is notified. Follow any guidelines appropriate to the nature of the death, like preservation of evidence in a homicide, etc. Prepare the body to be seen by family members. Potentially will be responsible for post-mortem patient care to prepare for transportation or autopsy. And of course, state and federal law and hospital policy need to be followed. And any death in the OR will be accompanied by thorough documentation. The surgical tech may be asked to assist with this documentation. So what do we do when there is a death in the OR? What do we do before the patient's family comes in to see their loved one? The procedure may vary between hospitals, but some examples are listed on this slide. So you're going to elevate the head of the bed to 30 degrees. Close the eyes, close the jaw. Place absorbent pads beneath the patient in preparation for loss of sphincters. Catheter, IVs, and tubes and other items are all left in place. Dress any visible wounds as though it's the end of a normal procedure. Protect any embedded foreign objects. Clean and wash the body and the hair, as long as it's not a coroner's case, which we'll talk about in the next slide. And complete any required documentation. Certain circumstances will cause a death to be ruled as a coroner's case. The circumstances listed on this slide would cause a death to be considered a coroner's case. Death in the operating room or in the emergency room. An unwitnessed death. Death after admission from another facility. When criminal activity is suspected. Suicide, death of a prisoner, death secondary to an infectious disease, workplace death. When working in a coroner's case, any evidence goes directly from you to them, the coroner. Having a patient die in the OR can be very difficult for the staff to come to terms with, and there are different coping strategies available to us as surgical techs. Remember to have empathy for one another and to do what we can to help each other come through the situation as well as possible. Know that there's a process to grieving over loss. Accepting your own grieving process and allowing it to take its course can sometimes help. Alternatively, you should recognize when help is needed in the form of support from counseling or similar options. Sometimes sharing what you're feeling with those around you is very helpful. Particularly, sharing your fears can help to make them more manageable. Working through the loss of a patient in the OR is a team effort, just like many of the other things that happen in the OR. There will often be the existence of support groups for staff, as well as for bereaved families. And finally, the hospital chaplain or clergy member can usually be of some help in grief as well. They're specially trained to help people with these types of issues. So this concludes our big, giant unit on biopsychosocial needs, death, and dying. Do remember to complete your discussion boards and the unit test this week. It's a big one since it covers a full 3 weeks of information.